Hello, we can't hear you. I can't hear you.
Okay. The following are the presenters of this session who have been conducting their research work in the field of medical laboratory sciences. Ms. Rashmida Silva, Ms. Chayani Welagedara, Ms. Tashmi Nirmanika, Ms. Deklanji Disanayaka, Ms. Sachini Adhikari, Ms. Balakitnan Jaikrishnan. We are honored to have with us Dr. KMN Kumarasinghe as the chairperson of this session. I would like to invite Dr. Darshana Kottahachi, Dean, Faculty of Allied Health Sciences, KDU, to give a brief introduction to the chairperson of this session.
Hello, we can't hear you. We can't hear you.
Okay, shall I read it? Okay. Okay. So let me introduce the chair of this session, Dr. Nishant Kumarasinghe. Dr. Nishant Kumarasinghe is a senior lecturer in the Faculty of Medical Medicine, General Surgeon Katulanda Defense University. He has obtained his MBBS from the Faculty of Medical Sciences, University of Srijagadhanapura in 1999. He joined the Faculty of Medical Sciences, University of Srijagadhanapura in 2002 and worked as a lecturer in anatomy up to 2013. He has obtained his PhD from the University of Newcastle, Australia in 2013. Then he joined KDU in 2014 and serves as the head of the Department of Anatomy, Faculty of Medicine up to date. Under his name, he has several high-quality international publications in the field of neuroscience and anatomy. Dr. Kumarasinghe has won several presidential awards for scientific publications from National Research Council, Sri Lanka. Dr. Kumarasinghe's research enthusiasm is mainly in neuroscience, anatomy, and exploring knowledge in indigenous medicine practice in Sri Lanka. Presently, he is the CEO in multidisciplinary project in KDU Care, which conducts palliative care and research in CKDU affected people in North Central of Sri Lanka. Sir, your presence is highly appreciated and I warmly invite you to chair this session.
Thank you, Dr. Kotahachi, for your kind words. And I think it's the time for us to initiate the session for today. I welcome you all, the people who are joining with us from internet via Zoom, and the people, all the scholars and the lecturers and the authors who are joining with us from here for the session of Medical Laboratory Sciences, session 1. So today we have 6 abstracts to be presented here. And first of all, let me introduce, let me welcome our the panel of judges. We have 2 very senior researchers as a panel of judges here, Dr. Chaturanga Ranavira and Dr. Chandana Ambalanduwa. Chaturanga is here with us at physically, and Dr. Ambalanduwa is joining with us. Can you hear us, Dr. Ambalanduwa? Via Zoom. So just to remind you all about the session, little bit of ground rules, maybe. Yeah. The session begins with introduction of the session theme and a brief in the title of the presenters. So in your first slide, you will be seeing that. And the whole presentation to be done within 10 minutes. After 10 minutes, the forum will be open for questions. So the questions can be asked during that maybe about 2-3 minutes will be given for the question. Maximum of 5 minutes will be given for the question and answering session. At 8 minutes, the presenters will hear a ring, the bell ringing. Okay. And at 12 minutes, there will be a tap of bell taps of twice we tap the bell, so that rapporteur will do that. Let me introduce my rapporteur, Dr. Mr. Widanagamage, and he will tap the bell twice, so that you have to stop. So then we will move on to the next presenter. So that's how it's it's going to happen today. And I urge you all to, we are still, I think we are a little bit running behind the time, so that I urge you all to, all the presenters and the question and answering, or all the scholars here joining with us electronically and physically both, and to stick to the time. So let me begin the session today, the first session, and first presenter here. And the topic of the first presentation is the prevalence of microalbuminuria in rheumatoid arthritis patients attending the Rheumatology and Rehabilitation Clinic at National Hospital, Sri Lanka. Our presenter here is GGRL D. Silva. So the session is open for Silva for the presentation.
Hello, am I audible?
Yes.
A very good morning to all of you. The chairperson, the board of judges, dean, lecturers, and HODs of Faculty of Allied Health Science KDU, guests, ladies and gentlemen. I'm Rashmi De Silva on behalf of our team. The topic of our research is prevalence of microalbuminuria in rheumatoid arthritis patients attending the Rheumatology and Rehabilitation Clinic at National Hospital, Sri Lanka. So what is rheumatoid arthritis? Rheumatoid arthritis is an autoimmune disease which affects multiple synovial joints, leading to bones and muscle damage. Rheumatoid arthritis causes long-term disability, morbidity, and mortality among RA patients. The prevalence of RA in the world population is estimated to be 0.3% to 1%, which is estimated to affect 165 million people. Rheumatoid arthritis is diagnosed according to the ACI-Euler criteria, which includes the joint distribution, serological testing such as rheumatoid factor and anti-CCP antibodies, symptom duration, and the presence of acute phase reactants measured using CRP and ESR. The major drugs administered for these patients are disease-modifying anti-rheumatic drugs, NSAIDs, and corticosteroids. As rheumatoid arthritis is a systemic inflammatory disease, it is associated with comorbidities such as osteoporosis, cardiovascular diseases, respiratory diseases, kidney diseases, Felty syndrome, and Sjogren syndrome. So when considering kidney diseases, 1 to 5% of RA patients are prone to have kidney diseases related to rheumatoid arthritis. If it can lead to kidney failure ultimately. Therefore, although the significance of the kidney dysfunction related to rheumatoid arthritis is not well evaluated in RA, it has become a cause for the mortality among RA patients. This renal dysfunction in RA can occur due to either the disease activity or due to the prolonged usage of nephrotoxic drugs. Amyloidosis and vasculitis occur due to the disease activity. Vasculitis is the thickening, narrowing, scarring, and weakening of blood vessels. When this occurs in the kidney glomerulus, it can lead to kidney damage. In amyloidosis, due to the inflammatory condition in the joints, interleukins and cytokines are produced in the body. These stimulate the liver for the production of serum amyloid A protein. Overproduction of serum amyloid A leads to the deposition of amyloids in the kidney glomerulus, leading to amyloidosis. Both vasculitis and amyloidosis cause glomerulonephritis, leading to proteinuria. If this kidney damage is untreated, it will lead to end-stage renal disease, which is irreversible, and ultimately it will cause kidney failure. Therefore, it is of utmost importance to assess the kidney function in rheumatoid arthritis patients. This subclinical renal dysfunction can only be investigated using laboratory investigations. Urine microalbumin and albumin to creatinine ratio can be used as investigations to identify the subclinical renal dysfunction in rheumatoid arthritis. So when considering the research problem, several researchers in the world have found that there's a prevalence of microalbuminuria among rheumatoid arthritis patients. However, there's no data available on the kidney dysfunction or the prevalence of microalbuminuria among rheumatoid arthritis patients in the Sri Lankan context. Therefore, in our research, the main objective was to investigate the prevalence of microalbuminuria in rheumatoid arthritis patients, while specific objectives were to determine the correlation of microalbuminuria with ESR and CRP, which are considered as biomarkers of rheumatoid arthritis. In the methodology, the type of the study was a cross-sectional study which included 50 rheumatoid arthritis patients selected from the Rheumatology and Rehabilitation Clinic of National Hospital, Sri Lanka. The inclusion and exclusion criteria were evaluated from each patient. The inclusion criteria were confirmed rheumatoid arthritis patients according to the ACR-ULA criteria, including both seropositive and seronegative patients with or without deformities, while patients having a clinical history of kidney diseases, diabetes mellitus, and hypertension, and patients who didn't provide their consent were excluded from the study. Then, the consent was obtained from each patient by explaining about the study and the relevant procedures clearly. Then, socio-demographic data, clinical history, and drug history were obtained from each selected patient through an interviewer-based questionnaire. Sample collection was done by a well-experienced nurse, where blood samples were collected for CRP and ESR investigations. Spot urine samples were also collected from each patient by providing the relevant instructions on sample collection. Spot urine samples were collected to perform urine microalbumin and albumin to creatinine ratio. In the analysis, ESR was done using the Welagedara method, while urine creatinine, urine microalbumin, and CRP were analyzed in a semi-automated biochemistry analyzer. Then the obtained results were analyzed statistically using the SPSS software version 20. The results of our research were as follows. Table 1 shows the socio-demographic parameters of the study population. In the selected 50 rheumatoid arthritis patients, the age of the patients ranged from 30 to 80 years with a mean age of 56. Out of these 50 patients, there were only 2 males and 48 females. The disease durations of the patients range from 0 to 30 years with a mean disease duration of 10 years. Out of these 50 patients, 44% of the patients were rheumatoid factor positive, while 56% of the patients were rheumatoid factor negative. When considering the laboratory investigations, the mean microalbumin value of these patients were 41.6 milligrams per liter, while the mean ACR value was 43.7. Our main objective was to investigate the prevalence of microalbuminuria in rheumatoid arthritis patients. In the selected 50 rheumatoid arthritis patients, within a period of 2 months, there was a prevalence of 40%, which is a considerable percentage. Our specific objectives were to determine the correlation between microalbuminuria and biomarkers of RA, which are ESR and CRP. However, there was no significant correlation between either ESR and microalbuminuria or CRP and microalbuminuria. It was the same for albumin to creatinine ratio as well. However, it was observed that there was a highly significant correlation between CRP and microalbuminuria and CRP and albumin to creatinine ratio among the elderly RA population of the study group. Therefore, it depicts that increase in age can lead to increased disease severity, leading to kidney dysfunction in these patients. Furthermore, a significant correlation was found between disease duration and albumin to creatinine ratio, along with an independent association between disease duration and albumin to creatinine ratio. Therefore, albumin to creatinine ratio can be independently used for assessing the kidney dysfunction due to long-standing rheumatoid arthritis. When comparing the rheumatoid factor positive and rheumatoid factor negative patient groups, we observed a significant difference in the mean microalbumin and mean albumin to creatinine ratio of these two groups. Rheumatoid factor is a marker of disease severity in rheumatoid arthritis. Therefore, RA patients who are rheumatoid factor positive are more prone to have kidney dysfunction related to rheumatoid arthritis. So finally, we concluded that there's a prevalence of microalbuminuria among rheumatoid arthritis patients, out of which in the selected study group it was 40%. However, there was no significant correlation between microalbuminuria and biomarkers of rheumatoid arthritis, which are ESR and CRP. According to our results, it clearly depicts that rheumatoid arthritis patients who are seropositive and elderly rheumatoid arthritis patients and RA patients with the prolonged disease duration are prone to have kidney dysfunction related to rheumatoid arthritis. Therefore, we recommend to include urine microalbumin and albumin to creatinine ratio as routine investigations in rheumatoid arthritis patients to assess their kidney function, so that we can take relevant measures to prevent this kidney disease, so that on the other hand, we can minimize or prevent the mortality rates of RA patients and provide them a good quality of life. And also, we recommend to conduct the same study employing a large study population. A case control study should also be conducted to investigate the exact cause for this kidney dysfunction related to rheumatoid arthritis, whether it is due to the disease activity or due to the prolonged usage of nephrotoxic drugs. The limitations of the study was the less number of samples collected due to the prevailing COVID-19 pandemic situation. The references and the acknowledgement are as follows. Thank you.
Thank you. Now the forum is open for questions.
So I'll go ahead and I'll ask the first question. Great presentation. I just want to know your thoughts about, in your presentation, you mentioned that there's no significant correlation between ESR and microalbuminuria and CRP and microalbuminuria. Do you think this sample size is big enough to conclude something like that? Or do you think that you will need to do further experiments?
Yes, sir. We have to do further experiment because our sample size is low and it can affect the significance of the test. And also another problem is that all the patients were on drugs, especially disease-modifying anti-rheumatic drugs. These drugs involve in lowering the ESR and CRP values. So that might be the reason for not having a significance between microalbuminuria and ESR or CRP.
Very briefly, you mentioned that you need to do conduct a case control study. Just briefly mention how would you do something like that for a study like this?
We have to obtain patients, newly diagnosed patients who are not on drugs, and we have to take a control study equal, within the same age range and having the same disease condition, so that we can analyze it by by taking the patient group with disease who are taking drugs and who are not taking drugs, so that we can, if the microalbuminuria was prevalent in patients who are not on drugs, then it can be, there's a bias that they have this kidney dysfunction related to the disease activity. So,
Thank you.
Okay, can you tell me why the male-female ratio is so different? Number of females are very high compared to the male patients.
yes, sir. Because rheumatoid in several researchers have found that rheumatoid arthritis is more prevalent among female patients, and they have mentioned the cause as there's no exact cause, but they're assuming that the genetic factors and the hormonal changes might be the reason for having a female predominance in rheumatoid arthritis.
Any relevant references regarding to your explanation?
Siegel et al. Have done a research and they have mentioned it in their research about that fact.
Okay, thank you.
Any further questions from the audience? Yeah, if there are no questions, we can move on to the second session. Thank you, Ms. Silva, for your excellent presentation. Our
Thank
next
you.
presenter is CSA Welagedara. The topic of presentation is detection of minimum inhibitory concentrations for Meropenem in resistant coliforms isolates at National Cancer Institute, Maharagama. So it's about the cancer patients, and you all know they are very resistant. Some of the bacteria found in them are very resistant to the antibiotics. So we would like to hear what interesting findings they have today. Now the podium is over to you.
Am I audible?
Yes, we can hear you.
Good morning, Chairperson, Board of Graduates, guests, and ladies and gentlemen. I'm Welagedara from the Department of Medical Laboratory Science, Research Coordinator. On behalf of my research group, I'm here to present detection of the minimum inhibitory concentration level for Meropenem in resistant coliform isolates at National Cancer Institute.
Sounds are not clear.
Can you talk a little loud? Can you talk a little loud?
Okay. Okay, am I audible now?
To some extent, yes.
Okay. So, first let's move to the introduction by explaining why we have selected this topic. Antibiotics are a group of drugs which treat diseases caused by bacteria. According to the mode of action, antibiotics are divided into broad spectrum antibiotics and narrow spectrum antibiotics.
Can you adjust the mic, please? Can you adjust the mic? I can't hear you clearly.
Hello? Am I
Okay.
audible now?
Okay.
Okay. Carbapenem resistant enterobacteriaceae is a health problem distributed worldwide due to overuse and misuse of antibiotics. Distribution method is the most common method when determining antibiotic susceptibility, but determination of minimum inhibitory concentration using blood microdilution is the gold standard in optimal treatment and identify microbial resistance. So, drugs that have become resistant by distribution method cannot be administered for patients. But if we know the MRCs, the drug can be further used by increasing the dose. Meropenem is a last-stage antibiotic drug which has been used. Resistance for this drug also is clinically high-risk situation. During our clinical visits, we have noted that Meropenem resistance is high at National Cancer Institute, Maharagama. Therefore, the study was designed to determine the prevalence of Meropenem resistance among coliforms and determine the MRC for Meropenem resistant coliform isolates using blood microdilution in National Cancer Institute, Maharagama. By now onwards, I am calling the NCIM for National Cancer Institute, Maharagama for ease of delivery. So these are the objectives of our study. Rather than I mentioned earlier, comparison of blood microdilution MRC values with the distribution method, comparison of automated MRC values and the MRC obtained from blood microdilution method for blood samples also were our objectives. So let's move into the methodology section. The study was an in vitro experimental study done at National Cancer Institute, Maharagama, in a 5 months of time period. Total number of meropenem resistant coliform isolates were collected from NCIN, and the test was performed at Faculty of Allied Health Sciences, Coding. When selecting meropenem resistant coliform isolates, these points were included and excluded. In there, especially the meropenem resistant zone diameter should be less than or equal 19 mm were highly considered. According to one of our main objectives to determine prevalence of coliforms, these response details were collected. And according to our main objective of determining minimum injury concentration, these are the steps that we have done in our methodology: sample collection, identification of meropenem-resistant coliforms, then inoculated Nakonke plants and incubated, then subcultured blood data for 24 hours day prior to test, and also preparation of meropenem working solution and preparation of 96 microalbuminuria plates and organism suspension included in the microalbuminuria plate, and finally installation the MIC after 24-hour incubation. These are some images of us performing MIC method in the laboratory. This is the growth microdilation method that we have performed. In here, we have duplicate all the samples, including quality control strains, to minimize our errors and to get precise and accurate results. Now let's move into our research findings. Prevalence. By considering the prevalence, in 5 months of time period, total sample count was 977. Among that total sample count, meropenem-resistant isolates were 494. Among these meropenem-resistant isolates, 332 isolates were coliforms. So, meropenem-resistant coliform isolates prevalence is high at NCIN, which is 67.2%. So, we have further categorized these coliforms into sample-wise, and we have noted urine and sputum has high meropenem resistance. Due to the pandemic situation, the laboratory access was limited and we were only able to collect 87 samples for our minimum injury concentration study. So in here you can see the obtained MRC values from growth microdilation method. In there, all the isolates were shown more than 1 micron using the MRC value, while 43 isolates showed more than 16 micrograms ml MRC value. In here, we have showed that MRC values among different segments. Why? In this table, we wanted to show that successfully growth microdilation method according to the CLSI guideline. Out of 87 isolates, 1 isolate was sensitive, while 12 isolates were intermediate. But in these all the 87 isolates in this diffusion method were resistant. Therefore, a statistical significant difference is noted between both methods. In here, we have done a comparison of automated MRC values with manual growth microdilation MRC values in order to complete one of our objectives. In National Cancer Institute, Maharagama, they have performed automated MRC for blood cultures only. So, among 32 blood cultures, 25 isolates with same results, but there were 4 different results. Therefore, also a statistical significant difference noted between both methods. Finally, as a conclusion, we can say that after increasing the concentration of meropenem to the maximum dose that can be administered to humans, meropenem-resistant isolates by distribution method will be were sensitive and intermediate by growth microdilation method. In Sri Lanka, determination of meropenem dose is based on results on distribution method, but this study emphasizes that determination of minimum inhibitory concentration is also effective. So, and also we have noted that Meropenem-resistant coliform prevalence was high at National Cancer Institute, Maharagama. Now let's move into the limitation and recommendations of our study. So this study was performed in single center, short time period due to pandemic situation, and number of isolates were limited due to the limited laboratory access. So we recommend performing multiple centers in large sample size to determine more precise values. It is better to consider MRC values, addition to results given by distribution method, and also it is better to investigate molecular mechanisms of the resistance pattern. These are the references, and we would like to express our greatest gratitude to our supervisor, Dr. Welagedara, our co-supervisors, Dr. Samaradiwakara and Dr. Senaratne, and others who helped us to make this a success. Thank you.
Now the forum is open for questions. Judges or any others joining with us can ask questions now.
I'll go ahead. Thank you very much, Mr. Welagedara, for your presentation. I actually wanted to know, like, how would you investigate the molecular mechanisms of related to meropenem resistance?
After selecting meropenem-resistant isolates, we can do molecular mechanisms by doing PCR method. So we have found in literature they have done some molecular mechanisms by PCR method. So that's how it should be done. Like into organism, identifying into organism level.
Okay, my second question would be, in your findings were like at least 50% of your samples were resistant to meropenem, at least. So, and at the same time, you recommend that you may have to increase the concentration that you may have to administer this drug to the patient, right? So if you keep on doing that one, so you may eventually hit an endpoint that you cannot use it any further. So how would you translate your finding, okay, this study to a clinical setting? What would you suggest in like practice wise?
Usually what they have done is when they found multi-drug resistant isolate, they normally antibiotics are given for like 7 days, like that. But they can increase the time period. That means 7 days stopping antibiotics. They can administer prolonged time period. So it would be this good start.
Okay, thank you.
Yes, do you all have any questions? So shall we move on to the next topic then? So our next presentation, the topic is the association of high sensitivity C-reactive protein and microalbuminuria with HbA1c level among type 2 diabetes patients in National Hospital of Sri Lanka. So our presenter today is KKT Nirmanika, and this topic will be very interesting because the diabetes very prevalent NCD, which is in Sri Lanka. So that they are here trying to find some association of high sensitivity C-reactive protein and microalbuminuria with another indicator, which is a long-term indicator in glycemic control, that is HbA1c level. So that we'll see how their findings are. Over to you. Please start.
I audible? Hello, am I audible?
Yes, we can hear you.
Yes, we can hear you. Please speak up.
Yes, we can hear.
Okay. Good morning, all of you. With the permission from head table and all present, on behalf of paper ID 191, research title, The Association of High-Sensitive C-Reactive Protein and Microalbuminuria with HbA1c Level among type 2 diabetic patients in National Hospital of Sri Lanka. I'm KKT Nirmanika, and with all of your permissions, I will take you all throughout my presentation. So first, let me give you a small introduction about how the things are built up. So as we are on type 2 diabetic patients, or known as diabetic mellitus, diabetic is a chronic metabolic disorder characterized by high blood glucose levels, which over time causes serious damage to the heart, blood vessels, eyes, kidneys, and nerves. So type 2 diabetic, also known as adult onset of diabetic, occurs when the body becomes resistant to insulin or doesn't make enough insulin. It's highly prevalent among adults aged between the worldwide. So when talking about diabetic, prolonged exposure to diabetic for more than 5 years often cause diabetic complications. Shown here is a collection of these complications. These complications can be seen in various organs in the body. These complications can be the microvascular complications or macrovascular complications. Microvascular complications examples are retinopathy, nephropathy, neuropathy, while some macrovascular complication examples are cardiovascular disease, stroke, atherosclerosis, likewise. So as we are on type 2 diabetic patients and we are on detecting a new method for diabetic nephropathy. Diabetic nephropathy is the microvascular damage to the kidneys due to diabetic. It leads to end-stage renal disease, and about 20 to 30% of people develop diabetic nephropathy. And when we identify diabetic nephropathy, it defined as the persistent albuminuria that is confirmed on at least consecutive 2 to 3 samples within 3 to 6 month period. It also reduces the glomerular filtration rate and elevates the blood pressure. So in talking about the diagnosis criteria of diabetic nephropathy is diagnosed by persistent albuminuria. So the common method of detecting albuminuria is albumin-creatinine ratio. Here the reference value is 30. Less than 30 milligram per gram is known as healthy, while 30 to 295 milligram per gram is known as microalbuminuria, and more than 300 is macroalbuminuria. And also we should know that diabetic nephropathy is not the only cause which causing albuminuria is not the only cause which causing diabetic nephropathy, and some other conditions like kidney disease in UTIs can also cause albuminuria. And when talking about research studies, in some researchers, they have said that prolonged exposure to type 2 diabetic more than 5 years can cause an ongoing acute phase low-grade inflammation in the body. Since this low-grade inflammation is due to diabetic, it's known as hyperglycemia-induced vascular inflammation. So they are saying that finally this can be lead to diabetic nephropathy. So with that in mind, we aim to estimate the high-sensitive C-reactive protein levels and albumin-creatinine ratio to determine the association with HbA1c level in long-standing type 2 diabetic patients. Here we have selected high-sensitive CRP because here it's a low-grade inflammation. So we can't detect by using standard CRP, so we have used HSCRP. And we have used albumin-creatinine ratio to detect. So it's a common method of diagnosis diabetic nephropathy. And the HbA1c level to measure the type 2 glycemic state of type 2 diabetic patients and long-term type 2 diabetic patients were included. So the research was done in National Hospital of Sri Lanka. Ethical clearance from the Ethical Review Committee of National Hospital of Sri Lanka was obtained. Subjects were recruited to the study on investigator-administered questionnaire form. Written consent from all the subjects were collected. In methodology, the patients with long-standing type 2 diabetic type 2 diabetic with more than 5 years of history, age between 18 to 70, but it included study, and individuals who are diagnosed as type 1 diabetic, patients with any kind of kidney disease, patients with chronic diseases, and females with gestational diabetic mellitus, gestational diabetic, patients who have been history of allergic reactions are excluded from the study, and patients who are taking anti-inflammatory drugs, aspirin, and lipid-lowering drugs are excluded from the study. These drugs are excluded because they are said that these drugs can affect the levels of diabetic nephropathy. So as we can't detect the effect of medications, we have excluded them. So we conducted research in National Hospital of Sri Lanka. We recruited 49 type 2 diabetic subjects into our research study. And from each patient, we done HbA1c, urine albumin, urine creatinine, and HsCRP. HbA1c was done to identify the glycemic state of type 2 diabetic patients. Urine albumin and creatinine was done to measure albumin-creatinine ratio and then diabetic nephropathy. HsCRP was done to identify the low-grade inflammation. In findings, first our primary data, we categorize into demographic data and investigational data. The most of the patients around 55 years old and the gender was nearly equally distributed. The duration was more than 10 years of most of the patients. And the HbA1c value was very high in most of the patients participated. Urine microalbumin, urine creatinine values both high, indicating microalbuminuria condition and albumin creatinine ratio. And HsCRP value was comparatively low. Then we did an independent sample t-testing. First, we categorized our HbA1c parameter into two groups, less than 7 and more than 7. Here we have used 7 as our cutoff value because it's a glycemic target for diabetic patients. So only urine albumin and HsCRP showed a positive or significant difference with HbA1c. And then we done t-testing for duration of diabetic. It was grouped into less than 10 years and more than 10 years. Only HsCRP showed a positive significant difference with duration of PM. So here both HsCRP value are significantly association. In findings, to see how our HsCRP values are distributed among patients, we draw a chart, and here the high values of HsCRP are clearly among the cutoff margin of microalbuminuria. So this is something interesting we found. And then in Pearson correlation, we did Pearson correlation for our main 3 parameters, HbA1c, HsCRP, and ACR. Only ACR and HsCRP showed a positive correlation, but it's also at 10%, not at 0.05%. And we also did regression, but it didn't show any association. So as a conclusion, for a better conclusion, here in the illustration, when we exclude the effect from medications, the duration of DM and HbA1c are interconnected. Why I'm saying it's interconnected? Because when the history of type 2 diabetic prolong is increasing, the HbA1c, if the diabetic condition is not controlled well, the HbA1c level is increasing, and these both lead to a low-grade inflammation in the body, which is significant by HsCRP. So this low-grade inflammation is indicating indicating an inflammation, and then lead to diabetic nephropathy by increasing albuminuria. So prolonged type 2 diabetic patients with poorly controlled HbA1c lead to low-grade inflammation and then microalbuminuria and then diabetic nephropathy. So these are the limitations and recommendations of our study. Reduced sample number was our first limitation, and extended studies in large in-depth investigations are therefore recommended. Sample clotted-in analyzing HbA1c, that was a sample collection error, so that was our limitation. And previous HbA1c levels from the onset of diabetes, we recommend because having more than 1 HbA1c value from the onset, it will be more helpful in detecting the glycemic state of the patient. And HsCRP cutoff value was a limitation because we couldn't use a manufacturer providing cutoff value due to some limitations. So for the investigations with further analysis methods are recommended. Medications interfere with HsCRP assay. We couldn't detect it, so it's a limitation. And future studies for detecting the effect of medications on the HsCRP levels are then recommended. So these are our references. So thank you for your kind attention and valuable time. So thank you.
Thank you, Nirmanika. Now the forum is open for discussion.
Thank you, Ms. Nirmanika, for your presentation. I'm just looking at the abstract that I have with me. So in that abstract that you have mentioned that type 2 diabetes patients that have not yet been well reported in Sri Lanka. Let me rephrase it. Like, does that mean this data that what we have here in Sri Lanka is not reliable? Is that what this statement says?
Yeah, in abstract, I said it that the correlation between HbA1c diabetic nephropathy was not well recognized in Sri Lanka. So that's all.
Okay.
Okay, now you were talking about type 2 diabetes mellitus. Do you know that some of the doctors, they recommend megadose of thiamine to reduce the diabetic nephropathy? What is your opinion regarding that kind of treatment?
There are so many medications that we are using for diabetic nephropathy. So thiamine is also.
I'm asking particularly for this thiamine megadose treatment.
Actually, we didn't.
You never came across?
No, we didn't measure the effect of medications on diabetic things. It's a lot. It will be a long research, so we didn't measure it.
Okay.
Any questions from the audience? So let me ask another question from you, if you don't mind. It's like, how do you say there's a correlation between low-grade inflammation and the nephropathy from your results? Like, how do you justify your results?
In our results, our sample size was limited, so we can't exactly say that there's a correlation. But to some extent, we got some positive correlations with HSCRP, with HbA1c, and also from the duration of diabetic mellitus, and ACR with HSCRP was correlated. So that's why we have decided there's some positive correlation, but it's not clear. So with our results, we selected it.
So if there are no such any other questions, we can move on to the next speaker. Thank you very much for your presentation. Our next topic is the simple, reliable alternative method to detect plasma hemoglobin in red cell concentrates for calculating percentage hemolysis at peripheral blood bank. Our presenter is C.A. Fernando. And yeah, if you're ready, you can start now.
Sir, am I audible and visual?
We can hear you, but still we can't see you. We can see you now.
Okay, thank you, sir. Good morning, I'm DMDT Desanayaka. Welcome to the presentation titled Simple, Reliable Alternative Methods to Detect Plasma Hemoglobin in Red Cell Concentrate Calculating the Percentage Hemolysis at Peripheral Blood Banks. The major limiting factor for the storage of red cell concentrate or hemolysis is hemolysis. To calculate the percentage hemolysis, we need to determine the plasma hemoglobin concentration. This is done by using the plasma low HB photometer or LHPP. But in Sri Lanka, in the government sector of Sri Lanka, the LHBP or the plasma low HB photometer is only available at the National Blood Center. So the general objective of our study is to design easy, reliable, and cost-effective methods for detecting plasma hemoglobin concentration to calculate the percentage hemolysis in RCC that are suspected for hemolysis in peripheral blood banks where there is no plasma low HB photometers. The specific objectives are: first, to develop a visual HB color scale. Second, to develop a standard region series, all these by comparing with the gold standard method LHBP. The methodology of both the two methods based on two basic main steps. First, we prepared a standard hemolysate from an unexpired whole blood, and from this standard hemolysate, we prepared a concentration series of plasma hemoglobin 0.1 gram per deciliter to 1 gram per deciliter, as shown in this figure. From the concentration series, we developed the two methods. First, the visual hemoglobin color scale or the CS method. Second, the standard hemolysate capillary tube comparison or the SCTC method. First, the visual hemoglobin color scale or the CS method was done by aspirating each of the concentration into capillary tubes, and they were aligned in the ascending order of the plasma hemoglobin concentration, and high quality photographs of them were taken under same lighting, same angle, and at the same place. From these photographs, a color series was prepared using the Adobe Photoshop CC 217 software, and that was finally printed on 230 GSM gloss laminated photo paper. The color scale we developed is shown in this figure. After developing this method, this was validated on 68 RCC that was received to a National Blood Center for percentage hemolysis determination. The second method, standard hemolysate capillary tube comparison method or the SCTC method, was done by aspirating each of the concentration into capillary tubes, and they were anchored on a standard hemolysate capillary tube holder that was made up of a hard board with a white background. After developing this method too, it was also validated on 68 RCC that was received to National Blood Center. Let's look at the application of both the two methods. First, the CS method. This was done by taking the supernatant of the RCC that we need to be tested into a capillary tube, and that must be compared with the colors in the color scale to determine the particular plasma HB concentration. In the second method, SCTC, this was done as same as taking the supernatant of the RCC that we need to be tested into a capillary tube, and that was compared with the concentrations anchored in the standard hemolysate capillary tube holder. Moving on to the statistical findings, in the Pearson product moment correlation, it proved that both the two models are highly correlate with the standard method LHBP. The correlation coefficient of CS method and LHBP was 0.986, and correlation coefficient R value between SCTC and LHBP was 0.987. According to the statistics of simple linear regression, we found the both models are highly significant, where the coefficient of determination R square value of CS method was 0.972 and R square value of SCTC was 0.974. Discussion. After finding out the plasma hemoglobin concentration from any of these methods, finally, we need to calculate the percentage hemolysis. This is done by using the standard formula percentage hemolysis equals free HB in the supernatant plasma in grams divided by the total HB in RCC in grams into 100%. According to the international quality standards and the National Blood Transfusion Services, the percentage hemolysis must be less than 0.8% for RCC to transfused. These developed alternative methods can help the peripheral blood banks for testing 1% of RCC monthly production, as they do it as a quality monitoring method, and testing RCC for hemolysis in a situation of temperature fluctuations in storage refrigerators or in any transportation errors. And also it might reduce time and cost, as the peripheral blood banks no need to send the RCC packs for percentage hemolysis determination to the National Blood Center. They can do it by themselves by these methods. And also it useful to test hemolysis in RCC, that is prior to an emergency transfusion of a rare blood group. Conclusion. According to the statistics, the two methods show a strong correlation between the gold standard method plasma low HB photometer. The study concluded that the two methods are cost-effective, reliable, and easy to be used in the peripheral blood banks to estimate the plasma hemoglobin concentration that is needed to calculate the percentage hemolysis. The limitations of our study were few studies were found to compare and review our study because this is a newly developed methods by ourselves. And also in preparation of the color scale, it was found that we wanted high quality equipments and advanced technology to get the true colors of the plasma. And due to the COVID-19 pandemic, we received only less number of RCC for validation of these methods. Recommendations are, we recommend to increase the number of RCC that we need to validate these both methods. And further, the study must be the study can be carried out by doing further statistical analysis of level of agreement to show how these two methods can relate with the gold standard method, and also repeated measure ANOVA for the stability to find the stability of the standard concentration series. These are our references. Our sincere thanks goes to the Director of the National Blood Transfusion Services and the Ethical Review Committee and the Medical Laboratory Technologies of the National Blood Center and the nursing officers. Thank you.
Yeah. Thank you, Ms. Desanayake, for your presentation. And we have about 2-3 minutes of time for the discussion.
So great presentation. I have just one question. So have you, as you mentioned, it's a simple, reliable method. So have you tried to use it in an actual clinical setting? Of course, you're supposed to translate your findings to a clinical setting later, I believe, but at least have you tried it?
So we tested some of the RCC packs, about 68 RCC, and we received that results. And we are further planning to develop this method by setting into clinical settings, by developing it, by giving it to other peripheral blood banks and testing that and doing the further studies.
So are you presenting this, are you presenting this physically or through the internet?
So through internet.
Through internet, isn't it?
Yes, sir.
Okay. So this is a pre-recorded presentation?
No, sir. I'm doing it physically through
okay.
Zoom.
Okay, all right.
One extra question. I mean, in order to develop that photograph, so the cost for those equipments and software and things like, for example, like peripheral center, I do believe they have to purchase those. I mean, pay for the softwares. I mean, like if you really want to, in order to standardize this method, right? I mean, let's say that you implement this in a peripheral blood bank or somewhere. How much would it cost roughly? Like, have you done some sort of estimation or something?
So it is just a simple method that we took photographs, high quality photographs, and it took the Photoshop CC 217 and we developed the color scale. And that can be printed on 230 GSM gloss laminated photo paper that we can keep it for a long time, which will reduce the mechanical damage and fading of colors, so that we can develop it and we can prepare it and give it to the peripheral blood bank so that they can keep for a little long time with that.
Okay. So you still have no idea how much the cost would be, right? I mean, just a general question. I mean, I was just curious about the cost. Simple.
Yeah, it's only the cost, sir, for the photographs,
Yeah.
and just the Photoshop software is readily available so that we can.
Would you have to purchase the actual paid version of Photoshop? I don't know. I'm just curious. That's it. I mean, like nothing else. But if you really want to use it as a standardized method, then don't you have to use whatever is accepted, right? I mean, if it is a software, then they have to use the same kind of instrument of processing and everything, right? I do believe.
Yeah, sir, we plan to prepare that color scale and distribute it to the peripheral blood banks, sir.
Okay, all right, okay, thank you.
Okay, thank you, sir.
Yeah, it's a very good presentation and very good topic to discuss. Actually, my suggestion is, it's a suggestion, not the question. So you should have studied the pre-hemolysis features, because if you want to implement as a method, you should have had a pre-hemolytic features, at least to have a retic count, right, in this blood packs before implementing the hemoglobin, because we don't know the pre-hemolytic features of that. That may interfere your final results. Do you get my question?
Yes, sir.
Yeah.
I got it.
So,
Thank you.
you can introduce the retic count measurement. Retic count measurement and see whether any hemolytic increase in retic count, that is pre-hemolytic feature. So in that sense, you cannot just apply to measure the hemoglobin in such cases. If the retic count is normal, then you can continue this. Okay.
So we found those plasma hemoglobin values from the HemoQ machine, sir. Standard. So those plasma hemoglobin values are found from the standard method plasma low HP photometer, sir.
No. When you are planning to implement it as a method of to implement in Sri Lanka.
Yes,
so
sir.
you have to have the pre-hemolytic features to say that there is no pre-hemolytic features, and that factor you have to consider for doing.
Okay, sir. Thank you, sir.
Then I have a bit of a general and a little bit of technical question, maybe. Yeah. Okay, you said your whole method based on the photograph you have taken with a high quality camera. With in your reference or in your whatever, maybe in the body or the methodology, I think it's better if you would have mentioned this the technical points like white balance, the color, whatever the technical parameters of your camera, at least the model of your camera.
Yeah.
Yeah.
So it is.
Yeah. And otherwise, that I mean, if it is a vaguely, if you tell something like it's a high quality camera, there are several high quality cameras. If you take a Kodak and Canon, their pictures are different, even with the same white balance, same parameter. So I think you need to pay attention to that.
So we took photographs from Nikon D7500 camera, sir.
And the shutter speed and the white balance and things like that, because they will and light ECG with artificial light you have used at the same time, because it's a colorimetric method based on the light and the darkness and the color and the instrument and all those things will affect your result. So,
yes, sir.
you need to pay your attention to that. Okay.
Okay, sir. Okay, thank you, sir.
Do we have any questions from the audience? Okay, if you don't have questions, we can move on to the next the presentation. Thank you, Ms. Disanayak, for your interesting presentation.
Thank you, sir.
Sorry. Please say. There's another question. Please say, Ms. Disanayak. Yeah.
Thank you for your presentation. I just want to confirm that you have mentioned there is the reliable test. So without having any single statistical parameter, that it is really needed to say that it is a reliable test. That is like a converge alpha value or the retest reliability. So though you are doing the validity test, how do you say that there is the reliable test for the people?
We tested on 68 RCC and we found that it was highly significant, and so that and highly correlate with the standard method, so that we concluded that it's reliable to find it the plasma hemoglobin concentrations.
Thank you for your answer, but the correlation is not the way to interpreting the reliability. So the reliability means two different definitions. So then you can change your title. It's not the reliability. Actual word is not the reliability. So whether it should be, I don't know whether it's the cost effective or not, but the word saying the reliability might not be appropriate.
Okay. Any questions? Okay, thank you for the audience for their interesting questions, and thank you, Mrs. Naik again.
Thank you, sir.
Yeah, it's time for us to move on to the next presentation. Our next topic is an attempt to detection of iron overload and its complications in beta thalassemia major patients at thalassemia unit Gunasekara by investigating some of the laboratory parameters. So it's a broad topic, and I invite AASR Adhikari to come up with the presentation. Podium is over to you.
Am I audible, sir?
We can hear you. Here.
Can you see my screen?
Yes, I can see.
We can see you, but you need to share your screen with us.
Yeah, sure.
Dr. Chandra, can you see the screen?
Yeah, I can see.
Okay.
No, the slideshow. Can Dr. Chandan see the slideshow?
No, I can't see the slideshow.
We also can't.
Yeah.
Adhikari, can you share your screen with us?
Yeah, sure, sir.
Has she given the sharing permission?
Arsan, macam ni pas boleh deh, macam ni conference ke judge panel lagi.
So can you see my screen?
I can see you, but your presentation is not visible.
Yeah. In that case, shall we move on to the next presenter, and then we will come back to you, Adhikari.
Yeah, okay, sir.
Don't worry, we will come back to you. Okay.
Yeah, sure.
So you work on your technical part at your side and try to see how you can show your presentation to us. Okay. Okay. Is our next presentation ready? Okay. So our next presenter is RMLS Karunatilaka. The topic is effect of hemolytic interference on lactate dehydrogenase activity in pooled normal serum. So again, another hematology topic. So that yeah, we are now ready to listen to you. Are you ready?
Yes, yes, sir, yes.
Okay.
It's audible, right?
Yeah, you're audible, and please share your screen with us.
I have shared the screen. Right, okay. So thank you. Good morning, ladies and gentlemen. It's my privilege to present the research thesis on the topic effect of hemolytic interference on lactate dehydrogenase activity in pooled normal serum at the 14th International Research Conference of General Sir John Katulanda Defense University. To start with, these are my keywords: hemolysis, lactate dehydrogenase, interference, and correction factor. So to introduce my topic, lactate dehydrogenase is a glycolytic enzyme and widely distributed in almost all the body tissues, especially in skeletal muscle, heart, liver, kidney, brain, lungs, and especially in red cells. So the serum LDH activity can be used as an indicator of cell damage. So as this LDH is present in the lungs, the increase in serum LDH level is observed in COVID-19 pneumonia too. So the clinical utility of serum LDH measurement that would be helpful in diagnosis and treatment of diseases such as myocardial infarction, kidney disease, muscle injury, pancreatitis, and many more. Especially, it is used to predict the clinical severity and to monitor treatment response in COVID-19 pneumonia. So these are the common interfering substances in our laboratory analysis, that is hemolysis due to hemoglobin, icterus due to bilirubin, and lipemia due to high triglyceride levels. So as our main concern is on hemolysis, what is a hemolysis? It's a release of intracellular components from red blood cell to the plasma or serum by the rupture of cell membrane. So that can be caused by contact of these red blood cell with foreign surfaces, improper phlebotomy and handling of specimens, inappropriate centrifugation, and improper storage and transportation of blood samples. Therefore, what is the relationship between LDH and hemolysis? So the hemolysis affects serum LDH activity and results in falsely elevated results, which is an error. So what is our research question is, we know that hemolysis causes false elevation of serum LDH. So whether we can prevent the false elevation, that means the error of LDH activity in hemolyzed serum. If so, any possibilities of correcting the error, right? So then we had a possible solution for that. If we can evaluate the effect of hemolysis on LDH activity, and also if we can calculate or find out the correction factor, then we can possibly correct that error, right? So as our objectives, the general objectives is to evaluate the hemolytic interference on LDH measurement in pooled normal serum, and the specific objectives are to determine the concentration of hemoglobin and as well as LDH activity in pooled normal serum, that is the baseline, and after addition of these hemolysates, again to determine the LDH activity and hemoglobin concentration of the final aliquots, and finally to evaluate the effect of hemolytic interference on LDH activity. Right. So the purpose of the study, then we know the 70% of the laboratory errors are due to pre-analytical errors. Therefore, this study would be useful in correcting the pre-analytical errors in serum LDH activity, and also it will be useful in conditions like paroxysmal nocturnal hemoglobinuria, in which there is in vivo hemolysis. Therefore, we can't avoid the hemolysis of the samples. Then it would minimize the unnecessary repetition of samples, therefore reducing the turnaround time, cost, and the workmanship of the laboratory personnel. And also, it prevents the wrong interpretation of the patient's conditions due to the false elevation of serum LDH. And also, finally, it would be helpful in diagnosis, prognosis, and monitoring treatment efficacy in diseases that use LDH as a biomarker. So, methodology, it's a laboratory-based experimental study. Blood samples were collected from healthy undergraduate students of Faculty of Allied Sciences, University of Jaffna. Sample processing was performed at Department of Biochemistry. So the inclusion criteria, healthy male and female students from first year to final year are eligible for the inclusion. And the exclusion criteria, students with the history of consumption of potentially hepatotoxic drugs, and also with history of diseases such as liver disease, hereditary spherocytosis, glucose 6-phosphate dehydrogenase deficiency, and other diseases were excluded. And the blood samples with visible hemolysis also excluded from the study. And blood samples were collected, and the EDTA sample and plain tube, EDTA sample to prepare hemolysates, and plain tube to prepare pooled normal serum. And pooled normal serum was prepared, and the stock hemolysate was prepared by freeze thawing method, and 20 different concentrations were prepared by diluting the stock hemolysate. So this is the procedure. We had prepared the pooled serum and allocated into 20 aliquots, prepared 20 different hemolysates with different concentrations, and each of the hemolysates were added into the allocated pooled serum individually, right? If you zoom that one, baseline LDH activity and hemoglobin concentration were measured in the pooled serum, and after adding the different kinds of concentrations of hemolysates, the final aliquots were measured for LDH activity and hemoglobin concentration. Right? The analytical consideration, LDH activity was measured by French Society of Clinical Biology, SFBC modified kinetic method, and hemoglobin concentration was measured by Ces Method hemoglobin method. All the analyses were performed in triplicates, and the results were validated using 2 levels of internal quality control materials. The results, the baseline measurements of the pooled normal serum of LDH was 202.38 units per liter, and baseline hemoglobin was below the limit of quantification, and we assumed as 0 grams per deciliter. Then the mean comparison, the concentration of hemoglobin were categorized into 4 groups based on the rate of hemolysis, and Dunnett's t-test was performed to compare mean with the baseline LDH activity. So it is a slightly hemolyzed, mildly hemolyzed, moderately hemolyzed, and severely hemolyzed. So especially this in our laboratory setup, what we do usually is a visual inspection of hemolysis, and we reject the sample. But these slightly hemolyzed samples, we cannot visualize in visual inspection. That is important. So in the p-values depicts that in all the subgroups, the mean differences were statistically significant when we compare with the baseline LDH activity. And then the correlation between LDH activity and hemoglobin concentration was evaluated using Pearson's correlation coefficient test. There was a statistically significant, strong positive correlation between LDH and hemoglobin concentration with the coefficient of 0.990. And the regression analysis was done, and it showed that with the increase of rate of hemolysis, the LDH was also proportionally increased, and a regression equation was formulated to predict the corrected LDH activity using the hemoglobin concentration. Right, this is the regression graph. Right, so to our knowledge, this is the first study to report the regression equation to correct the LDH activity in the hemolyzed sample. So ethical clearance was obtained from Ethics Review Committee, University of Jaffna. All the ethical procedures were followed. Some studies were deviated from our results, but most of the past studies were in concordance with our results. So the difference may be due to the sampling technique and geographical location. So to conclude, serum LDH activity was increased with the rate of hemolysis. significant mean difference even at hemoglobin concentration 0.005 grams per deciliter was observed, and there was a statistically significant strong positive correlation between LDH and hemoglobin concentration, and also there was a linearity of 0.68 demonstrating 86% association of LDH activity with hemoglobin concentration. So the limitations of the study, only hemoglobin concentration was used as the indicator of cellular lysis. Bilirubin and other interferences were not considered. The recommendations for the studies, including different and larger populations using different techniques of measurement, LDH and hemoglobin concentrations are recommended, and including patients with red cell membrane abnormalities is recommended, and also correction factor. The equation should be validated with different baseline LDH activities in different populations. So the take-home message: measure free hemoglobin concentration in all serum samples which are requested for serum LDH activity, and the interference can be corrected using the correction factor. So this is the formula that we can use to predict the corrected LDH activity. So these are my references. We authors thank the participants who gave the specimen to conduct this study. And also we thank the KDU IRC 2021 selection committee for selecting our paper for oral presentation. Thank you very much.
So now the session is open for discussion.
Thank you very much, Mr. Karunathilake, for your presentation. I have one question. How, apart from hemoglobin, how would you measure the cellular lysis? What parameters can you use reliably for the measurement of cellular lysis, cell lysis?
Yeah, we can use beta galactosidase activity.
So can you explain a bit further for the audience if you don't mind?
Just I know that beta galactosidase is also another marker for cellular lysis. So here we have only measured hemolysis. So that is one of our limitation here. So if possible, I don't think that there are methods and centers available in Sri Lanka to measure beta galactosidase activity. I'm not sure.
Okay. Now, Chaturang, do you have any other questions?
Yes, I just one quick question. So you mentioned actually, why on earth that no one had really thought about correcting this before, like using a correction factor? Why do you think people have not thought about it? Why do you I know that you mentioned that this is a first study. Why do you think that people have not really thought about this part before?
Actually, the LDH measurement usually they visually in our laboratory setup. If the samples are hemolyzed, they usually reject the sample and request for a new sample. So some studies, they have done it on automated analyzers, the corrected correction factors, but not in the manual method.
Yeah, thank you.
Okay, I have one question.
Yes,
what is the concentration of LDH inside RBC?
That is almost 10 times. So it depends on the hemoglobin concentration also of the personnel. So it is mostly 10 times more than the plasma level.
You mean within the RBC?
Yeah.
So what's the big deal? When RBC ruptures, LDH comes out.
Yes, sir. So here we have mentioned that we have reported a correction factor. So that is the new thing. We know that LDH will be falsely elevated in the hemolyzed samples, but here we have.
No. My argument is something different, right?
Yeah.
Now, due to some other reason, RBC ruptures.
Yes.
Then LDH will release into the plasma serum, right?
Yes. Yes.
So then automatically LDH concentration goes up.
Yes.
So then how can you justify the correction factor and other things?
So if we can measure the hemoglobin concentration of that particular sample using this formula, we can calculate the corrected LDH activity. That means without hemolysis. But we have to validate this equation.
Okay.
Any questions from the audience? Any comment? Views? So, shall we move to the next one? Okay. We are inviting again Ms. Adhikari for the presentation. Can you come up with the presentation now, Ms. Adhikari?
Yes, sir. Sorry for the inconvenience.
All right. Please share your screen with us. You can start now.
Yeah, sure. Good morning, everyone. The title of our presentation is An Attempt to Detection of Iron Overload and Its Complications in Beta Thalassemia Major Patients in Thalassemia Unit Kurunagala by investigating some of the laboratory parameters. I am the one of the author, A.A.S.R. Adhikari, who is here to present the research findings. Thalassemia is the commonest single gene disorder in Sri Lanka. As you see the classification, thalassemia can be classified into two main groups, alpha thalassemia and beta thalassemia. In alpha thalassemia, the reduction of alpha globin chains in Hb molecules, hemoglobin molecules can be seen. In beta thalassemia, the reduction of beta globin chains in Hb molecules can be seen. According to the rate of reduction, these two types of thalassemia can be categorized into major, minor, and intermediate types. In our study, we mainly focused on beta thalassemia major patients. The main problem in beta thalassemia major patients is the destruction of red blood cells. So that these patients need long life through time blood transfusion for long time living. So that as a chronic complication of long-term blood transfusion, iron overload may be result. To excrete the excess iron, iron chelation therapy can be used as a monitored treatment method. Beta thalassemia major patients may have a lot of complications, but these are the common complications: splenomegaly, hepatomegaly, growth retardation, and paleness. When we consider about the laboratory diagnosis of the beta thalassemia major patients, we can have hematological investigations. Mainly, we can get full blood count report. In full blood count, HB level is low, RBC platelet may be normal, MCV level is low, HCT is low, RDW is high. Also, we can use reticulocyte count and blood picture. In blood picture, microcytic hyperchromic red cells can be seen due to the morphological changes. As special investigations, HB electrophoresis, HPLC, alpha-beta ratio can be used. Iron overload in post-blood transfusion will result organ damage due to the excess of iron. In such a case, increased level of serum ferritin can be observed, as well as the biochemical parameters such as liver function test, renal function test, endocrinological investigation results may be changed due to the organ damage. The general objective of our study is to detect the organ-related complications of beta thalassemia major patients in iron overload and chelated status using some of the laboratory parameters. After gaining the ethical approval from the teaching hospital Kurunagala, we have selected 68 patients, including 78% of males and 22% females. We included patients who confirmed for beta thalassemia major, history of taking iron chelation therapy, and age 2 to 35 years, and excluded patients who are having history of iron thalassemia trait, intermediate, history of jaundice due to viral, alcoholic, or heavy metal inducers, and patients with malignancies or inflammation or infectious conditions. After the selection of the population, the patients were informed about the study protocol and consent was granted. The laboratory parameters were obtained from BHTs at 6-month interval after initial iron chelation therapy for maximum 2.5 years. The data was statistically analyzed by SPSS version 20. Then the finally correlations were established. We find associations between serum ferritin, AST, and serum creatinine because these are the only parameters that were available at the moment of our examining points. The initial observations of our study is we noticed that most of the serum ferritin values are more than 1000 nanogram per milliliter and some are in 450 to 1000 nanogram per milliliter. When we consider about the AST levels, all the AST levels were in upper range and there is no any observable change in serum creatinine values. Mainly, our research findings can be divided into two groups. That means we found correlation among different parameters and correlation within the same parameters. As we collected the data at 6 months of interval post-iron chelation therapy, we found that 6 months of serum ferritin is correlated with 6 months of AST value. It's a negative correlation. By analyzing this association furthermore, we were able to create an equation including serum ferritin and AST level at 6 months of post-iron chelation therapy. When consider about the correlations among same parameters, first we found 6 months of serum ferritin is correlated with 18th month and 12th month of serum ferritin. Then 6 months of AST correlated with 30th month of AST and 12th month of AST. Finally, the 6 month of serum creatinine correlated with 18th month of serum creatinine and 12th month of serum creatinine. These correlations may use to predict the future lab values of beta thalassemia major patients for the patient management. As a derivative finding in the distribution of AST values from post 6 month to 30th month of iron chelation therapy, we found that rising tendency of AST value in 18th month of post iron chelation therapy and decreasing, so that we can predict the complications arises with the increasing AST levels of beta thalassemia major patients and make pre-arrangements. Finally, as we found the associations between serum ferritin, AST, serum creatinine, we can predict the lab values, future lab values of beta thalassemia major patients and simply can screen the early organ damage of those patients. The limitations of our study, the study was performed considering both iron overload and chelated status of beta thalassemia major patients. And this is only an attempt to detect the early organ damage. For recommendations, can increase the sample size and time duration of the study, can increase the number of parameters or include the specific parameters that could be used to screen the post complications in organs, can examine the social status of participants that may affect the outcome during the period of the study, can maintain the consistency of doses of iron chelators, and can increase the duration of the post-iron chelation and obtain the lab values. These are the references. Acknowledgement. First and foremost, we humbly express our gratitude to the Department of Medical Laboratory Science of KDU, Faculty of Allied Health Sciences, General Sir John Kotalawala Defense University for giving us this opportunity and their measureless guidance. Our sincere gratitude goes to our supervisor, Dr. Swarna Gunathilaka, consultant hematologist, National Thalassemia Center, Teaching Hospital, Kurunagala, for her valuable guidance and commitment throughout the project that enabled us to complete it successfully. Also, we are immensely grateful to our co-supervisor, Dr. Darshil Kottahachi, Dean, Senior Lecturer, Faculty of Allied Health Sciences, General Sir John Kotalawala Defence University for his enthusiasm, continuous guidance and support given. Finally, we acknowledge all those who helped to conduct this research successfully, including all the participants. Thank you for listening.
Now the forum is open for discussion. Any questions?
Thank you very much, Ms. Adhikari. I'll go first. This is just for my information. In one of your probably at the right at the end of your slides, you actually showed a graph of, about where the AST level increased and decreased after the iron chelation therapy, right?
Yes, sir.
So how do you explain that this the increase and decrease gradually?
Yeah, as we shows in 18 months of post-iron chelation therapy, AST levels got increase in this study. So we can imagine, we may think that it may rise due to the iron overload in the initial phase of the iron chelation therapy, and it may gradually decrease after 18th month of iron chelation therapy due to the effectiveness of iron chelation.
So you're saying that even after the iron chelation, still the AST levels could increase, then gradually decrease, right? Is that what you're saying?
Yeah, no, as we perform this study, considering both iron overload and chelated status, we can't directly say this is because of iron chelation therapy or iron overload.
Okay,
so
great.
that, yeah.
Yeah, that's
So that,
yeah. Thank
yeah.
you. I got it. Yeah, thank you.
Yeah.
Okay, now you have obtained all this data from the VHT, isn't it?
Yeah, sir.
Yeah, so that means if you take 6 months or 1 year, I don't know how can you believe all these data, because these analysis are done by some laboratory technologies, isn't it? Depending on the instrument and the operator of the instrument, the data can vary. If you increase the number for 1,000 or 2,000, we can at least, believe something. But your sample number is low, therefore you cannot conclude definitely, what you have done. That is my personal feeling.
Yeah, yes, we collected a lot of laboratory parameters, but we have to collect data for get the correlations. Normally, the serum ferritin is tested at 6 months of intervals, so that we only gain the data at 6 months of intervals. So if some data was not there and some are not in continuous iron chelation therapy, so that we have to exclude a lot number of patients from our study, as it's a attempt to detect, and we have to increase the most organ related parameters, and we have to increase the sample size as well as.
Okay, now at least if you have done analysis by yourself for a single parameter, then you can compare your findings and the other laboratory technologies findings, whether they are, in par with your findings. So,
yeah, sure, sir. But due to the COVID restrictions, we can't move to the laboratory of the thalassemia unit Kurunagal, and they not allowed us to get into the laboratory and perform tests. So that's why we plan to conduct this study as a retrospective cross-sectional study.
Okay, thank you.
Thank you very much, the judges, for their very relevant and interesting questions. And do we have any questions from the audience? Okay, time is also up. Thank you, Mr. Adhikari, for your excellent presentation. And yeah. Before the conclusion of the session, I think it's our last presentation. We have another? This is the last one. Have you got it?
No.
This is the last one.
Yeah.
Yeah. It's the last one. And yeah, first, before just concluding the session, and first let me thank the organizing committee, starting from the Dean, Faculty of Allied Health Sciences, and the Department of MLS, and the organizing IRC organizing committee, as well as the technical team from KDU, and for their wonderful job of organizing this hybrid session. And next, thanks goes to the presenters who came up with their interesting research findings, and the two judges who came up with very interesting as well as very relevant and valid questions, so that that made this session very success. So, having said that, I should officially conclude the presentation session. Thank you very much for your interesting participation.
Thank you, sir. After interesting research presentations and Q&A sessions, we have entered to the memento awarding ceremony. I cordially invite Dr. KMN Kumarasinghe, chairperson of the session, to give the mementos to the judges of the session. I would like to invite Dr. Chaturanga to take his memento of appreciation by chairperson. Thank you, sir. I would like to invite Dr. Chandan Ambalandue to take his memento of appreciation. He was joined with us online. So on behalf of him, I would like to invite Dr. Rajit Silva to take his memento. Thank you, sir. So please stay a while. I cordially invite Dr. Darshana Kottahachi, Dean, Faculty of Allied Health Sciences, Kotelawala Defense University, to offer the memento in appreciation to the chairperson of this session. Thank you, sir. On behalf of the organizing committee, thank you, sir. On behalf of the organizing committee, I would like to thank to the chairperson of the session, judges of the session, and to the presenters. And our sincere thanks also goes to the audience for your participation for this session. Now we would conclude the technical session 2 of Allied Health Sciences of the 14th International Research Conference, KDU. Thank you.